Shall we start, sir? I'll just give a
Yeah,
small
sure,
intro
sure.
and I'll hand over the session to you.
Okay, okay.
Very good evening to one and all who are present here. On behalf of Medusane, I welcome each and every one of our subscribers for joining us in the live session. Today we have Dr. Athul Francis, sir. He's a consultant pulmonologist in MAG Hospitals, Edapalli, Cochin. He is here with us for a session on COPD. Welcome, sir. The session is on yours.
All right. So, am I audible? Audible, right?
Yes, sir, you're clearly audible.
Okay. So, today we'll be discussing a topic which is very important with your respiratory point of view. Uh, it's a very common condition both for your theories in as well as your practicals, because majority of the cases even in my UG which I saw was COPD. So what is COPD? So why is COPD important? COPD is one of the top three causes of death worldwide. 90% of deaths in the middle and low socio-economic countries, and the numbers tend to increase in the coming years. So that is why COPD is a very important entity when it comes to respiratory diseases. So whenever you're talking about the respiratory system, more than I think around 60 to 70% of your patients which you see will be mostly the airway disorders. So in the airway disorders, the most common ones which we see is one, as we all know, is asthma, and the another is COPD. Then you have other conditions like bronchitis, etc. But most of them are likely secondarily, it's a sequelae of an infection. So many of the times, most of your practice relies on asthma and COPD. And in a low socioeconomic country like India, COPD is one of the most common lung disorder which we see. And the problem with COPD is it is a progressive condition. Therefore, early detection and initiation of treatment is very important in COPD. Unlike in asthma, asthma is not like a progressive condition. Once you identify an asthmatic and you treat an asthmatic, he will definitely improve. He'll have an acute exacerbation, but he'll recover from the exacerbation as well. That is basically when we come to the definition of COPD. So basically, you have something called as GOLD. GOLD, as we all know, is Global Initiative for Lung Diseases. So gold is the gold standard of COPD. They meet every once a year, and they have an update which comes out every year on World COPD Day. So this is when they release the guidelines every year. So that is why gold guidelines are important, because that is why the management changes, the definition changes, and there has been a rampant difference in the definitions and the management practices from the time I studied and from what is being followed now. Now, this is basically, it's a long definition, the goal definition. I have divided it into three parts. So, and I'll explain why it is so. Firstly, COPD is a heterogeneous lung condition. Now, what do you mean by heterogeneous lung condition? As we all know, bronchial asthma is something which mostly affects your medium-sized airways. Okay, it affects the medium-sized airways. But the thing with COPD is it can affect any of your anatomical portion of the lungs. Okay. So COPD can affect any of the anatomical portion of your lungs. It can affect your airways. It can affect your alveoli. It can affect your bronchi. Like that is where we call as what we call as bronchitis, right? So basically that is why it is an important pathogen. It's a heterogeneous lung condition that is it can affect any part of your lung, right from your bronchus, right from to the other parts of the bronchial tree to your smaller airways. And it is your emphysema comes into picture. When the bronchus is involved, that is when you call it as bronchitis. Later, when your airways gets involved, that is when your small airways get involved. That is when we call as COPD. So anything less than 2 millimeter, any airway diameter less than 2 millimeter is what we call as a small airway. So in COPD, your most common site of involvement is the small airway. So the first part of the definition is that COPD is a heterogeneous lung condition. Secondly, you have chronic respiratory symptoms. So this is another important point. You have a chronic respiratory symptoms in COPD. Whereas in asthma, you will have an acute symptoms. Like a patient has an acute exacerbation of asthma, you will have increase in breathlessness, wheezing. It might be accompanied by fever, etc. But in COPD, you have chronic respiratory symptoms. You have cough, dyspnea, and sputum production that is present throughout the year. And the dyspnea, all these progress. So all these are progressive. Your dyspnea is a progressive dyspnea, and sputum production, when we say the sputum production, the classic history which the patient gives is early morning, he has large amount of expectoration. So that is one clinical feature which we always associate with COPD or even in smokers. So as I told, it's a chronic respiratory condition and you have symptoms that progress over time. And the third point is what I told in the first. It can be due to abnormalities of your alveoli. It can be due to abnormalities of the airways. Therefore, it can affect any part of your bronchial tree. And as we told, it's a persistent condition. That means it's not reversible and it is a progressive airflow limitation. Whereas when we are talking about asthma, in asthma, when we say it is something which is called as a reversible airflow limitation. That is when it means in even if you do a spirometry, which is your basic of PFT testing, you get a reversible airflow limitation. Once you use an inhaler, your FEV1 will improve. Whereas in COPD, it is a progressive and persistent airflow obstruction. That means, or a airflow limitation. That means it is not reversible in most of the conditions. Only in certain overlap condition, there might be a slight amount of what you call reversibility. So just remember, when we are talking about the definition of COPD, remember these 4 points. It's a heterogeneous condition. It can cause chronic symptoms, often progressive symptoms, and the main symptoms are cough, dyspnea, and sputum production. Due to abnormalities, it can involve the abnormalities of the airway or the alveoli, and the airflow limitation is persistent, often irreversible, and it's a progressive airflow limitation. Now, earlier whenever we were talking about COPD, we normally say that COPD is a disease which is greater than 40 years and mostly seen in smokers, which is not the case right now. But earlier, when we used to say that COPD is mostly a condition that occurs in an age group of more than 40 years, then something came up called the term called young COPD. So young COPD is seemingly straightforward because it directly relates to the chronological age of the patient. Given that the lung function peaks, usually your lung function peaks at around 20 to 25 years of age. So basically, if you are plotting your lung function in a curve like this, if you're plotting your lung function gradually, it just picks up, and there's an exponential curve when it around the age of 20 to 25 years. Then it plateaus for some time, and then it starts reducing. Therefore, the peak lung function or the peak FEV1, that is the forced expiratory volume in first second, which is a measure of your lung function, is the peak. The peak of the lung function is around 20 to 24 years. So anything which way, if a patient can get a COPD in the age group of 20 to 50 years, that is when we call it as a young COPD. Then you have something called as a pre-COPD. Pre-COPD is a patient, when I'll be talking about diagnosis of COPD, I'll be saying the criteria which is needed. So basically, for diagnosing COPD, you do a PFT, and in PFT, you get airflow obstruction, which is non-reversible. But pre-COPD is a condition. As the name suggests, it's pre-COPD. That is, before the patient is going to have COPD, he goes into a pre-COPD. Like you say for malignancy, before you have various stages of malignancy, like anaplasia, metaplasia, etc. Or if you take the case of diabetes, you have something called as a pre-diabetes, in which your HbA1c is between 5.7 to 6.5. In the same way, you have something called as a pre-COPD. That is the stage before COPD. Now, why is pre-COPD important? If you are able to identify the patient in a pre-COPD group, you will be able to prevent COPD from occurring. Just like you get a pre-diabetic patient, you identify it, advise the patient lifestyle modification, you can prevent him from developing diabetes at a later date. So in pre-COPD, the patient has respiratory symptoms, but in PFT, there is no airflow obstruction. So you don't have a documented evidence to prove COPD, but you have symptoms of COPD like cough, sputum production, and dyspnea. Now, coming to classification of COPD. Now, the classification of COPD earlier, the terms which we all knew for COPD, at least for your level, there is something called as chronic bronchitis, and there is something called as emphysema, right? So these are the two broad classifications which we have of COPD. Now, basically, what we are discussing here is this is an advanced classification of COPD. So basically, we need to identify the cause of COPD. So here they are classified COPD according to the cause. So you have something called a COPD G. G means it's a genetic COPD, and the most common cause, as we all know, is alpha-1 antitrypsin deficiency. Then you have something called a COPD D. D means developmental abnormalities. That is, if the patient has a premature, if the patient was prematurely born, if he had low birth weight, if he had early life events, and if there was a history of maternal smoking, all these factors can have a adverse effect on your lung function. So that is what is called as COPD-D, or developmental abnormality COPD. Then you have environmental COPD. The most common which we know is COPD-C, that is a cigarette smoking COPD. And this is something which is coming up in a huge way. So biomass and pollution exposure COPD. Then COPD due to infection, that is post-infectious, like your childhood infections, tuberculosis, your post-TB sequelae, and your HIV-associated COPD, etc. And then you have COPD asthma combination, which we earlier used to call, or even right now we call it as what we call it as um, COPD asthma or ACOS. Earlier we used to call it as ACOS. So from here, from this classification itself, you can find out what are the causes of COPD. So one is genetics, second is developmental anomalies, third is environmental exposure in that, third is cigarette smoking of any type. It can be cigarette, tobacco, everything. Fourth is due to biomass exposure. Fifth is air pollution. Sixth is post-infectious. Seventh is if you have a childhood asthma, it can obviously progress towards COPD in a later date, and you have so many COPD of what you call as unknown cause. So basically, what in a nutshell, COPD, you have an etiology, you have your smoking, which is the most common factor. You have air pollution, you have biomass exposure, etc. Host factors, if the patient is immunocompromised. Then your main pathobiology is you have impaired lung growth, you have accelerated decline in lung function, you have increased incidence of lung injury, you have systemic inflammation. And pathology, as I told, it can affect any part. It can small airways, it can cause emphysema, and it can produce systemic effects as the complication. These are usually complications of COPD. Pathogenesis I'll be discussing in detail in the coming slides. And you have airflow limitation. And the important point to note in COPD is you have what I called as persistent airflow limitation and sometimes progressive airflow limitation. And clinical manifestation symptoms, as I already told you, cough, dyspnea, and expectoration. You have exacerbation, that is worsening of symptoms, and you have comorbidities, which I'll be discussing. So what are the disease development and progression? Now coming to COPD, as we already saw in the classification of COPD, which helped us in finding the causes of COPD. As I already told, the environmental factors like your cigarette smoking, this is the most important cause of COPD. Now smoking can be any types. It can be your cigarettes, cigars, tobacco chewing, which we call as non-smoking COPD, even vaping. So even e-cigarettes are not that safe. So all these factors can cause COPD. And the second point to note here is there is something called as ETS, or secondary smoke, right? Or what we name in easy terms, passive smoking. So if you have a patient who you see symptoms of COPD and he is a non-smoker, always ask for history of passive smoking. Secondly, tobacco use anytime, and the tobacco use, the cause COPD due to tobacco use is very high in low socioeconomic countries. Third is genetic factors. The most common genetic factor which you should remember is alpha-1 antitrypsin deficiency. And obviously air pollution. With the increase in air pollution, whenever you are talking, just for your there are three things which you should remember in air pollution. One is the air quality index, which you would have been reading in newspapers. Poor air quality, increased chance of COPD. Then you have something called as PM 2.5. So this is what we call as particulate matter 2.5. So this is basically the 2.5 is any particle which is between the size of 1 to 5 micrometer or less than 1 micrometer can go deeper into your lungs and cause COPD. So that is what the funda is here. So basically just remember the most common cause is cigarette smoking. You have tobacco smoke, you have genetic factors like alpha-1 antitrypsin deficiency, you have air pollution. Then as we discussed earlier, there can be infections, post-infectious and developmental anomalies, especially if you are premature, low birth weight, if there is history of maternal smoking. Okay. And one more point to note here is asthma in long run can progress to COPD. And one more factor, even with your air pollution, what I can say is biomass exposure or biomass fuel. And the biomass fuel commonly includes your wood, cow dung, etc. Okay. So now I hope you have understood the pathogenesis of COPD. What are the causes of COPD? Now, in the later slides, I'll be discussing how these factors can cause changes in your lungs, in your airways, in your alveoli, and in your bronchi. All right. So basically, as I told, it has chronic bronchitis, emphysema, and sometimes it also includes, some textbooks also include small airway diseases like bronchiolitis. Now, what is chronic bronchitis? So chronic bronchitis, the definition is very important. It is defined as cough with sputum production for at least 3 months a year for 2 consecutive years. So here, if you see, as I told, COPD can affect any part of your bronchial tree. Here, mostly your bronchus, the small and large size airways like your bronchus is affected. So bronchus, if you check in the histology of bronchus, you have something called as a mucus secreting goblet cells, etc. So there will be a mucus producing glands which are seen, and there is hypertrophy of the mucus producing glands. So basically, if this is your airway, so this, just imagine this is your bronchus. Okay, so this is the normal size bronchus. In chronic bronchitis, what happens is, so basically your airway epithelium has so many endothelial cells, etc., or the epithelial cells which has mucus producing glands. So this mucus is normally important because it helps in flushing out the noxious particles from your body, just like in your nose, in the same way. But what happens is in COPD, due to chronic inflammation or in bronchitis, there is excess of mucus production, and the mucus producing cells gets hypertrophy. That is, there is increase in number and there is increase in size as well. So your bronchus, which is normally like this, it may end up becoming like this. So the airway then will have to pass through a narrow tube that will create a bronchitis. And because, and why is there excess mucus production? Because there is a hypertrophy of the mucus secreting glands. So this is one common variety of emphysema, or sorry, COPD, which we see. Many of the COPD patients in early stages will present with chronic bronchitis. So that is important. The most important thing is the definition. And one more thing for you people to find out, in, you would have read it in patho, there's something called as Reed's index. This is mainly seen in your histopath. It's not a clinical definition which helps you in finding out bronchitis. Reed's index is a histopathological finding in which you compare the thickness of your mucus and the submucous area, and there's a particular value which you need to find out. So that is how you diagnose chronic bronchitis. But for us as clinicians, it's mainly symptom based. If the patient has cough with expectoration for more than 3 months in 2 consecutive years, that is when we call it as chronic bronchitis. Now coming to emphysema. In emphysema, when we are discussing, the most important point in emphysema is the definition of emphysema. Everything that I have put up here, those in red is important. Now, What is emphysema? It's an abnormal permanent dilatation of the airways distal to the terminal bronchiole, accompanied by destruction of the alveolar walls and without obvious fibrosis. So there might not be fibrosis. There will be development. There will be a permanent irreversible abnormal permanent enlargement of the air spaces distal to the terminal bronchiole, and it is accompanied by the destruction of the alveolar walls. That is, there is airway remodeling and without obvious fibrosis. And the part of the lung normally which is involved is what we call as a respiratory acinus. So how does it look? So basically, here if you see, here you have a terminal bronchiole, then you will have your respiratory bronchiole. All right. And this is how your acinus normally looks. So basically you have your terminal bronchiole, then you have your respiratory bronchiole, and the respiratory bronchiole is what which opens into the alveolar ducts and the alveolar sacs. So basically, when we are talking about emphysema, as the definition it is clear, distal to the terminal bronchiole. Therefore, the area which is involved is distal to the terminal bronchiole. So here if you see, this is the terminal bronchiole, and the area distal to that you have your respiratory bronchiole, you have your alveolar ducts and the alveoli, and here you have the septum. Now, depending on which part of your respiratory bronchiole or the which part distal to the terminal bronchiole is involved, you can classify emphysema anatomically. So that is where you have different types, like you have a centriacinar emphysema, you have your panacinar emphysema, you have your irregular emphysema, and you have your centrilobular emphysema. So, and parapsychiatricial emphysema. Sorry. So basically, the centrilobular emphysema means the area distal to your terminal bronchiole is affected. So it is affected only here. Irregular emphysema means the involvement is completely irregular. Septal emphysema means the area distal to your terminal bronchiole, that is mainly your alveolar ducts and your alveoli is affected. So centrilobular means mainly your what did I tell you? Your respiratory bronchiole is mainly affected. Paraseptal means distal to your respiratory bronchioles areas are affected. Irregular, as the name suggests, is an irregular patchy framework. So basically, if you see here you have your terminal bronchiole. It is opening into the respiratory bronchiole, and all this is an alveoli. So this is basically a cross section. Here, if you see A, is, as I told, is a centriacinar or centrilobular. That means only your respiratory bronchiole is affected. So what type of emphysema is this? This is a centriacinar emphysema. Secondly, what we saw is the paraseptal. So paraseptal means distal to the respiratory bronchiole. So here, if you see, the B is paraseptal. That is the distal acinar area. That is the alveolar acinus. C, if you see, it's a panacera. It's a panlobular. The entire alveoli is affected. That is what you call as a panlobular emphysema. And for D is irregular. That is some involvement here, some involvement not there here. Okay. So that is how you remember. So basically, you have to remember this diagram. That is your terminal respiratory unit. You have a terminal bronchiole which opens into the respiratory bronchiole, and this respiratory bronchiole further opens into your alveolar duct, alveolar sacs, etc. And if your respiratory bronchiole is affected, that is what we call as a centrilobular. When your terminal bronchiole, when your respiratory bronchiole is affected, that is when we call it as a centrilobular emphysema. Then if your alveolar and alveolar duct is infected, that is what we call as a paraseptal emphysema. So just remember this also for a quick revision. Respiratory bronchiole, it's a central, what we call as a centrilobular emphysema. If it is a alveolar duct and the alveoli which is affected, that is a paraseptal emphysema or your distal acinar emphysema. Then your panlobular when the entire thing is affected, and irregular means irregular patchy involvement. So centriacinar emphysema is most commonly seen in smokers, and it's an upper lobe predominant on a chest X-ray, or basically in your lungs. The centriacinar emphysema is basically seen in the upper lobe. And then your panacinar emphysema is mainly caused due to alpha-1 antitrypsin deficiency, and it is mainly seen in the lower lobe of the lung. Therefore, your centriacinar emphysema is mainly seen in the upper lobe. It is more common in smokers. Your panacinar emphysema is what is caused by alpha-1 antitrypsin deficiency, and it affects the lower lobe of your lungs. Then you have paraseptal and parapsychiatricial emphysema, irregular. The parapsychiatricial emphysema is usually post-infectious. All right, I hope you are getting it. Now, this is the diagram, and this diagram is something which is important. Okay. Now, what are the risk factors which we already discussed? Smoking, indoor air pollution, occupational pollutants, low socioeconomic status, and the host-based is genetic and airway hyperreactivity. Now, smoking, as we all know, there is most important contributor factor to COPD. There is something called as a smoking index. Then you have something called as pack years of smoking, which you have to learn in your clinical classes. And the degree of FEV1 deterioration contributes to the amount of smoking. That is, increase in the basic common sense, increase in the amount of smoke, increase in FEV1 decline. That is, there will be a more steeper drop in FEV1 the more you smoke. Now, this is basically just for your understanding. This is something called as something which we learn in PSM, that is the Plexure Pato curve. So this is basically to show how grave smoking is. So here, if you see a patient, this is the age. On x-axis, you have the age. On y-axis, you have something called a FEV1. This is basically your lung capacity. Now, if you see here, the red line is a patient is smoked regularly and susceptibility to its effect, but he stopped smoking at the age of 65. Supposedly, if he stopped smoking at the age of 65, his age got increased at least by a period of 10 years. Okay. Now, if he stopped smoking at 45, there was further increase in his lifespan. And if he was never smoked or not susceptible to smoke, you see how his lifespan goes. So basically, if a patient is a smoker and even after diagnosis of COPD, he is not smoking cessating, that means he will have an earlier death. If he smokes at the age of around 65, his lifespan is a bit increased, but he will still have some amount of disability and he'll still have death. Now, supposedly, if he stops at age of 45, that means he's likely to have a very, other than smoking related causes, due to smoking, his lifespan may not get that affected and he may not even develop a disability. So that is why the cornerstone of treatment of COPD is smoking cessation. And the earlier you stop smoking, the more useful it will be. Supposedly, if you are already a smoker and you are smoking and you stop smoking only after the age of 65 or after the age of 70, you will inevitably have a disability and you will inevitably have a death. So this is very important. This is asked in PSM as well. So just remember. Now, secondhand smoke and prenatal smoke, as I already told, secondhand smoke is what we simply call as passive smoking. Prenatal exposure, as I told, if the mother is a chronic smoker or if she had smoked during pregnancy, there is increased chances of the child, the newborn having COPD in the future, along with asthma and along with other lung disorder. The kid is also he also has a propensity to end up in having some sort of a developmental disorder in the lung. Now, indoor air pollution, as we all know, occupational exposure, people who are employed in factories, etc. Low socioeconomic status, childhood respiratory infection that causes a secondary COPD-I or COPD secondary to infection. HIV is very, very important. HIV is an independent cause of COPD. So remember, because HIV causes the activation of alveolar macrophages and MMP. So if someone can ask you, can HIV cause COPD? Yes, HIV is an independent risk factor for COPD because it causes activation of your alveolar macrophages and there is increase in the matrix metalloproteins. Okay. So HIV, and especially if you have an HIV with very low CD4 counts. All right. Now coming to host factors. So basically what happens in COPD, you have something called as, usually you have something called as elastase. And you have something called as anti-elastase. Okay. So basically, if you are taking your airway like this, a basic framework of your airway is made up of something called as a elastin fibers. Okay. So elastin fibers are the basic framework of your airways. Now, what is elastase? Elastase is something which, as the name suggests, it destroys the elastin. Now, anti-elastase or anti-proteinase is something which has a negative feedback on elastase. Therefore, if you have a anti-elastase, you will have low levels of elastin. So usually there is a balance between the amount of elastase and anti-elastase. And because of this, your airway integrity is maintained. So this is the basic funda here. So what happens is alpha-1 antitrypsin in genetically, if you see, alpha-1 antitrypsin is an anti-elastase. That is, it prevents the degradation of elastin because it has a negative effect on elastase. But whenever you have alpha-1 antitrypsin deficiency, there is increase in the level of elastase that will cause increased destruction of the elastin. There is loss of your airway framework, and this can result in COPD. And similarly, when you are so that is why genetically alpha-1 antitrypsin, then your other genetic component is BMP, that is bone morphogenic protein. And you have something called as airway hyperresponsiveness. Airway hyperresponsiveness is a genetic thing. So whenever you have some air pollutant or a smoke or any inflammation entering your airways have a tendency to respond in a hyper manner. That is increased response when compared to a normal, just like your allergy. Allergy is something genes which are there in everyone, but there are some people in which there is increased release of histamine. In the same way, there is increased airway hyperresponsiveness, which causes increased mucus production. And this increased mucus production can cause bronchitis, which later progresses to COPD. And there is, because of all this, there is a persistent airflow limitation. Now, coming to risk factors, as there are two factors, as we know, one is cigarette smoking and genetic susceptibility. Your most common is alpha-1 antitrypsin deficiency. So all these factors, there are mainly cells. The main cells involved in COPD is macrophages, neutrophils, epithelial cells, and lymphocytes. Whereas if you take asthma, your main cells in asthma is your eosinophils and serum Ig, your serum Ig, or that is from your B cells, your immunoglobulin. But whenever you are talking about COPD, your most important cells are the macrophages, your neutrophils, the surface epithelial cells, and your lymphocytes. Now, what does macrophages do? Macrophages, as I already told, there is something called as a protease anti-protease imbalance. So this protease anti-protease imbalance, whenever your patient is a smoker or genetic susceptibility, the macrophages is as patients through molecules like MMP12, that is the matrix metalloprotein 12, and SERPINA1. SERPINA1 is the gene which is affected in alpha-1 antitrypsin deficiency. Therefore, whenever there is a defect in SERPINA1, there is decreased alpha-1 antitrypsin production, which increases the protease effect, and that causes extracellular matrix destruction. One more point to note here is don't confuse between protease and antiprotease. It is the same as your elastase and anti-elastase. This is just a different term. Mechanism of action, everything is same. Then neutrophils, as we all know, neutrophils are increased in acute inflammation. Neutrophils have various molecules which causes oxidant and antioxidant damage to your airways, lungs. And the main this is not that necessary for you. This can result in chronic inflammation. Similarly, the epithelial cells get destroyed over time, resulting in cell death. And lymphocytes are important for lung repair. But what happens in COPD, there is an ineffective lung repair. And this ineffective lung repair can result in airway destruction. Okay, so your lungs are not getting displayed. So basically, easily, if you want to say pathogenesis or COPD, you have a genetic susceptibility, you have protease, anti-protease imbalance. This causes increased destruction of your elastin. And this increased destruction of elastin can destroy your extracellular matrix. That means your matrix is destroyed. There is neutrophils causing chronic inflammation, and there is ineffective repair. That means your matrix which is destroyed, it's not getting repaired properly, and there is a permanent airway remodeling. Okay, so this is the basic pathogenesis of COPD. And if someone asks you what are the cells involved, macrophages, neutrophils, and ineffective repair caused due to lymphocytes. Now, the airflow limitation, as I already told in COPD, it's a persistent airflow limitation, often progressive airflow limitation. You have low FEV1 by FVC, that is normally you say less than 0.7. Now, according to latest guidelines, you say something less than LLN. LLN means lower limit of normal. Now, what is LLN? Because your the airway, the normal FEV1 by FVC can vary from person to person because of the age, height, weight, etc. So you have the universe. Some studies have shown that this 0.7 cannot be applied universally to everyone. So that is where lower limit of normal comes into consideration. So basically what happens is, supposedly just remember this is your lungs, okay? So if you have your lungs, as we all know, there is a bronchus which is coming here. You have alveolar sacs, small airways, etc. here. So what happens in COPD, as we already saw, these airway walls are getting destroyed. So because of these airway walls getting destroyed, their elastin component is gone. Elastin is important for maintaining the elasticity of the lungs as well as the compliance of the lungs. Okay. So if you take a small airway as a single cross section here, so supposedly this is a normal airway. Okay. Now, because of your destruction, your normal airway is gone. That means your airway is like this. So what happens in COPD is there is ineffective emptying. That is, during inspiration, air is entering into your lungs, but during expiration, this air is not completely going out of your lungs. The air is getting trapped here. So that is what we call as air trapping. I hope you understood. What happens is here, so if you see a diagram here, this is your normal lung, this is your normal airway, and this is your alveoli. Now, what happens in emphysema or any other COPD disorder is your alveoli is completely destroyed. So because of this, if you see, there is no effective framework or a supportive framework of your airway is destroyed. So supportive framework is gone. So when the supportive framework is gone, the lung during expiration, when your airway has to close, it is not able to close properly. That means, so because of this, your air is not completely leaving the airways. And because of this, there is a air which is getting trapped. So this is what is called as air trapping. Now, air trapping, when your air gets trapped for a long, long time, as it is going on trapping, it develops into something called as a hyperinflation. That is, your lung is filled with all types of air and the air is not getting pumped out. So that is why in X-ray you get a hyperinflated lung field in COPD. So this is the basic funda of COPD. So coming to airflow limitation, is a persistent progressive airflow limitation, and there is loss of elastic recoil. As I told you, your airway supporting framework is gone. There is no elastic recoil, and because of no elastic recoil, the air is not getting pushed out, and this can result in air trapping. Now, alpha-1 antitrypsin deficiency, a quick word. I already told you the pathogenesis. Alpha-1 antitrypsin is the most common antiproteinase, but due to alpha-1 antitrypsin deficiency, there is less antiproteinase activity. And the most common, it is a codominant condition, autosomal recessive condition. It affects chromosome number 14, and it causes what type of emphysema? Pan-acinar emphysema. And PIZZ is the most common deficiency. That is, just remember, in alpha-1 antitrypsin deficiency, PIZZ is the most common deficiency, and the most common chromosome involved is chromosome number 14, and it causes a pan-acinar emphysema. Now you have something called as a, so basically now you come here. So this is what I told. So this is your normal lung. Now what happens in COPD, as I already told, that there is a loss of elastic recoil. So because of loss of elastic recoil, there is air trapping, your airways are getting distended. And because of this, your diaphragm is getting flattened. Then there is shortening of the diaphragm muscles. There is increase in radius of curvature, and there is finally air trapping. So this is why there is a flattening of diaphragm. Basically, just remember, so this is your normal airway. Your walls are getting destroyed. There is no emptying. Your airway is getting bigger. And finally, it becomes so big that your diaphragm gets pushed down. And what happens to the diaphragm muscle fiber? There is shortening of the diaphragm muscle fibers. There is increase in radius of curvature, and there is decreased zone of apposition. So all these factor causes hyperinflation, or hyperinflation can cause all these changes in the diaphragm. And because there are so many changes happening in the diaphragm is unable to push the air out completely. And that is why a COPD patient finds it very difficult to take breath. And that is why it keeps progressing. So all this doesn't happen in one day. It happens over years. And these are the various changes which can happen. So basically, you have your inflammatory cell accumulation, etc. So this is also another easy flow chart. You have macrophages which are getting activated, antioxidants due to neutrophils. So all these factors will cause epithelial cells injury, matrix destruction. You have increased mucus production due to airway hyperreactivity, and you have emphysema. All this will finally cause COPD. Okay. This is also another easy this thing. Here you are genetically predisposed due to alpha-1 antitrypsin deficiency. You have environmental factors like COPD, smoking, pollution, etc. This will cause inflammation. Inflammation will cause oxidative stress from through the neutrophils, and there will be neutrophils and the macrophages which are activated. There is a protein antiproteins imbalance. There is increase in the level neutrophil elastase and matrix metalloproteases. There is destruction of the alveolar walls and the alveolar capillaries. Because of this, there is a decrease in elastic recoil. And because there is a decrease in elastic recoil, as I told you, there is air trapping, there is enlarged air spaces, and there is ineffective emptying. So ineffective emptying means your carbon dioxide levels are getting, carbon dioxide is getting trapped in your airways. And because of this, there is a ineffective emptying which is occurring, and there is air trapping. This causes emphysema, and there is narrowing of the airway due to mucus hypersecretion and other things which causes chronic bronchitis. So this is the protease, antiprotease. So here if you see matrix metalloprotein 1, matrix, all these are proteinases. That is, they destroy your extracellular matrix. And your antiproteinases, the most important which we should remember is your alpha-1 antitrypsin. So just remember that. And just remember it's a serine proteinase. And the gene involved, even a alpha-1 antitrypsin, the defective gene is your SERPINA1 gene. So this is the pathogenesis basically of COPD. Now, alpha-1, I already told you. Now, basically, now you have come to the, you have understood the pathogenesis, you have come to symptoms, and now you have to establish the diagnosis. So for establishing our diagnosis, we have something called as spirometry or PFT. Now, the symptoms, as we already told, there is chronic cough, your dyspnea. The dyspnea is usually progressive over time. You have chronic sputum production, and you have risk factors like smoking, alcohol, etc. So you just have to, smoking, pollution, etc. You have to take a proper history. So patient history taking is very important. And past medical history, make sure you ask about asthma, allergies, TB, any childhood infection, any low birth weight, etc. You can ask how the COPD develop. And so COPD is mostly, as we told, it's seen in a older age group. So history, your present history is important. That is your symptoms, cough, dyspnea, etc. Your past history is important with respect to infections. Family history, you can ask of any lung disorders. Personal history, very, very important. Smoking history. Your occupational history is important to see whether there's any pollutant exposure or anything of that sort, any chemicals, or whether his house is located somewhere near to the factory, whether he is coming from an area which is highly polluted. You should know the basic demography, because many of the times you get a lot of cases of non-smoking COPDs. Now coming to comorbidities, also you can ask whether there is heart diseases, osteoporosis, etc. And impact of disease on patients. Like this is very, very important because it guides in management. Now, examination in chronic bronchitis, you have something called as polycythemia, and you have cyanosis. You will have, now coming to the examination finding, when you are looking at a systemic examination of your respiratory system. In examination, you will get a classical barrel-shaped chest. There will be use of accessory muscles of respiration. There will be a forced expiratory time greater than 6 seconds. So basically, what do you mean by forced expiratory time? It's the time which is required to push your air out. So normally when you are taking a ratio of 1:2, your inspiration takes around 1 second, your expiration takes about 2 seconds. But in COPD patient, it can progress to more than 6 seconds, because as we already told, the elasticity is gone. Therefore, there is no power to push out the air which is there. And you have a hyperresonant node because of air trapping. You can have rhonchi, you can have crepitations. So this is how a normal spirometry curve should look. We'll have a separate discussion on that. You have FEV1, you have FEC. So this is how a normal curve should look. Now what happens in COPD? There is obstruction. That is, there is decrease in, just remember these points more than enough. There is decrease in FEV1. Your FEC is more or less normal. Now, how does a decrease in FEV1 will look in spirometry? Your FEV1 value is reduced here. So here, if you see, this is the normal FEV1 of a person should be 4 liters, but in COPD it can come up to 1.8 liters. And your FEV1 by FVC ratio, which is very, very important, it will be less than 0.7. Okay. Or less than, as I told earlier, lower limit of normal. So very important there. Now, basically, now you can classify COPD into mild, moderate, severe, and very severe based on your spirometry finding. So you have, if your FEV1 value is greater than or equal to 80, the first criteria is FEV1 by FVC should be less than 0.7. Now, after that, you go into FEV1. If your FEV1 is greater than 80, it is mild. Between 50 to 80 is moderate. Between 30 to 50 is severe, and less than 30 is very severe. So this is very, very important. Now, basically, depending on the FEV1 criteria, greater than or equal to 80 is mild. Between 50 to 80 is moderate. Between 30 to 50 is severe, and between less than 30, it is very severe. So this is important. This is the assessment of COPD. Now you have something called as a MMRC. This is basically your clinical postings you would have discussed. Your MMMC grading of breathlessness, your 0, 1, 2, 3, 4. 0 means you have breathlessness only on strenuous exercise. 1 means you are feeling breathlessness climbing up a slight hill. MMRC grade 2, you walk slower than your peers on a flat road, or you will have to stop for breath when walking on your own pace on level ground. MMRC 3 means you stop for breath after 100 meters. And MMRC grade 4 means you are too breathless to leave the house, or you are breathlessness when dressing or undressing. So this MMRC criteria is very, very important. And even while taking history, you should ask which level of breathlessness is he in. Now, all these factors are very important when you are coming to the diagnostic point of view. Similarly, you have something called as a CAT assessment score. The CAT assessment score is COPD assessment test. This is basically a test in which you have different questionnaire. This is basically a questionnaire. And if just remember that you have a CAT questionnaire, and if your score is greater than or equal to 10, that almost always points towards COPD, greater than or equal to 10. You needn't by heart this questionnaire. Just remember there is something called as a CAT or a COPD assessment test. Now, how do you go about diagnosing COPD? So basically, firstly, you have symptoms of the patient. Then you did a PFT. You found a FEV1 by FVC is less than 0.7. Then your second step, as we told, is to grade the obstruction, whether it's mild, moderate, severe, or very severe. Greater than or equal to 80, 50 to 79, 30 to 49, less than 30. Then you do something called as an exacerbation frequency. That is, if the patient had greater than or equal to 2 moderate, then you go into, so just focus here. We'll cut it off here. Now we just focus on the table here. You can divide COPD into 3 categories, that is A, B, and D. This is important for management. On x-axis, you have MMRC scores and CAT score, which I showed you. So if your CAT score is less, so you can make 2 tables here, CAT score less than 10, CAT score greater than or equal to 10. Similarly, MMRC between 0 to 1 and MMRC greater than or equal to 2. And on y-axis, you have 2 points, that is 0 and 1 moderate exacerbation not leading to hospitalization, or you have greater than or equal to 2 moderate exacerbation, or greater than or equal to 1 leading to hospitalization. So this is important because you have different treatment for categories A, B, and D. So firstly, you find that FEV1 by FVC is less than 0.7. Then you classify COPD into mild, moderate, severe, and very severe. Then you look for assessment of symptoms or risk of exacerbation by forming this table called A, B, and D. In x-axis, you have 2 points. One is MMRC 0 to 1 and MMRC greater than or equal to 2. CAT score less than 10, CAT score greater than or equal to 10. And on the y-axis, you have 2 points. One is exacerbation frequency, greater than or equal to 2 moderate exacerbation, or greater than or equal to 1 leading to hospitalization. That is the topmost point. and 0 or 1 moderate exacerbation not leading to hospitalization. So this is important in diagnosis of COPD. So that is how we go. What are the differential diagnoses you have for COPD? One is asthma, as we know, but asthma, it's more seasonal. It is not a progressive condition. There will be a family history of asthma. Congestive cardiac failure, he'll obviously have a history of congestive heart disorder. Then bronchitis is mostly post-infectious. He'll have large volumes of purulent sputum. He will have recurrent cycles of infection. TB, as we all know, you can identify it from the clinical features. Then you have something called obliterative bronchiolitis, diffuse pan bronchiolitis, which are very, very less common, and it's mostly seen in a younger age group and mostly associated with connective tissue disorders. Okay, so this is important. So this table is very, very important. And when we look here, so this is basically a treatment I'll be discussing in some other later class. I'll be finishing with pathogenesis and clinical findings here. Just remember, in group A, you can use any bronchodilator. Group B, you can use a LABA plus LAMA. That is a long-acting beta agonist and long-acting muscarinic antagonist. And in group B, you can use a LABA plus LAMA, and there is a point of adding a steroid as well. All this is for a separate class on treatment of COPD. Okay. So this is how an X-ray of a COPD patient looks. The most common findings which we find is you have something called as a flattened diaphragm. You have a tubular heart. Okay. And you have a hyperinflation. So those are the main findings which we see in a, this is in a vertigo level. Okay. Now, management of COPD, I'll be discussing it in a later class. Now, we'll just have a quick recap of what we saw today. Firstly, we defined what is COPD, goal 2025. We saw that it's a heterogeneous lung condition. It is characterized by symptoms of cough, sputum production, and dyspnea, which progressively increases. Third point, it can be caused by the abnormalities in your airways or in your alveoli. And the fourth and the most important point is it's a progressive condition and it's a persistent airflow limitation, which differentiates it from asthma. Now, coming to the risk factors of COPD, then we saw there's a classification of COPD depending on the causes. It can be either COPD C, or the COPD due to C, that is due to cigarette smoking, COPD D due to developmental anomalies, COPD A, which is COPD asthma. Then you have COPD I, which is caused due to COPD, which is caused as a post-infection. Then you have COPD U, which is what do you call as a what do you call it as a idiopathic COPD. So these are the various points which are there. Then when we are talking about COPD, the risk factors we already know from the classification which we saw. Then you have chronic bronchitis, in which you have mucus hypertrophy of the mucus producing gland. You have symptoms for more than 3 months for 2 consecutive years. Then you have emphysema. The point to be noted is which part of your lung is involved, distal to the terminal bronchiole. And depending on the involvement, if the respiratory bronchiole is involved, it's entry acinar. If your alveolar ducta acini is involved, it's a pan acinar. Then you have paraseptal, you have irregular emphysema. Then emphysema affects which chromosome? Chromosome number 14. It called the PIZZ is the most common abnormality which is seen in emphysema. And now coming to the pathogenesis of COPD, which we told, uh, basically you have all these factors. There's an imbalance in the proteinase and antiproteinase. There is increased activity of the proteinase, which is caused due to cigarette smoke and your genetic factors. Because of the increase in active of the proteinase, there is increased extracellular matrix destruction. And there is, although there is a matrix destruction which is there, the repair is ineffective. This effectively decreases in, causes destruction of your alveoli. Because your alveoli is destroyed, there is decrease in the support of your airways. There is decrease in the elasticity. This decrease in elasticity causes air trapping. This air trapping can progress into hyperinflation. So that is the whole pathogenesis, and your key mediators are your macrophages, your neutrophils, your lymphocytes, and your epithelial cells. Macrophages, because it causes proteinase, antiproteinase imbalance. And your most common one here is your SERPINA1 gene and your matrix metalloprotein 12. And neutrophils, how does it cause? It causes oxidant and antioxidant damage, resulting in a chronic inflammation, causing bronchitis and mucus hypertrophy. Lymphocytes, why are they important? It's not a it causes ineffective repair. And the most important, COPD, you have spirometry. In spirometry, you have an FEV1 by FVC ratio. And if your FEV1 by FVC ratio is less than 0.7, that is how you diagnose a case of COPD. Okay. Now, firstly, you go FEV1 by fitting it into different criteria depending on your FEV1. Then you go into group A, B, and D depending on your MMRC classification, your CAT score, and your number of exacerbation in the previous 1 year. Then you classify it into A, B, and D, which is important for your treatment. Treatment I'll be discussing later. And basically, you have something called as a pink puffer and a blue blotter. This is my last point for today. So blue blotter is what you see in chronic bronchitis, and pink puffer is what you see in emphysema. I'll explain you the concept here. Now, what happens in emphysema? In emphysema, as I already told you, there is airway. It is mainly the distal airways. There is loss of alveolar support. There is hyperinflation which occurs. Now, because of the hyperinflation which is occurring, although your airway is being, there is ineffective ventilation which is occurring. There is ineffective removal of carbon dioxide. So this causes a VQ mismatch. And this VQ mismatch causes something called as a increased minute ventilation. And because of this, there is what is called as a pink puffer. So just remember, pink puffer in emphysema, they'll have dyspnea, they'll have cough, they will have increased minute ventilation, they'll have all your pursed lip breathing, you have accessory muscle use, cachexia, hyperinflation, barrel chest, etc. Blue blotter is mostly seen in chronic bronchitis, because what happens in chronic bronchitis, it is your larger airways which is involved. The airway is getting narrowed. There is ineffective perfusion which is occurring. So because of ineffective perfusion, there is defective oxygenation. And because there is a defective lesser amount of oxygen in your blood, that causes cyanosis. Whereas in emphysema, or there is nothing like a lesser amount of oxygen in your airway. The airway is filled with oxygen, but your carbon dioxide is unable to move out. So that is what is, and this causes a VQ mismatch. That means there is a perfusion which is getting proper, but there is a defective in ventilation which is occurring. There is high minute ventilation. And just remember, chronic bronchitis patients will always have polycythemia, and they have increased pulmonary hypertension because of chronic hypoxia. So just remember these tables from your point of view. Pink puffer and blue blotter. Pink puffer in emphysema. The pink puffer is mostly a very thin, lean patient who has a pursed lip breathing. The mechanism of pursed lip breathing is, pursed lip breathing is done so that you increase the intrathoracic pressure or transthoracic pressure to push the carbon dioxide out. As I already told, in emphysema, there is difficulty in removing the carbon dioxide. So only way you can try to remove carbon dioxide from your airways is by increasing the pressure in your airways. That is increasing your transthoracic pressure. So always air moves from high pressure to low pressure area. Increasing pressure, trying to move it out. That is why you get a pursed lip breathing. Whereas in chronic bronchitis, as a symptoms, as I told you, there is hypoxia, which results in cyanosis. And because of chronic hypoxia, pulmonary vasculature, as we already know, is the only area which responds to hypoxia as constriction. Therefore, there is pulmonary vasoconstriction, which crosses to chronic cor pulmonale, and there will be secondary polycythemia, which is secondary to hypoxia. And chronic bronchitis patient will be more obese, blue color, mild. He'll have lesser amount of dyspnea. He'll have more amount of protective cough. Whereas emphysema patient will have more amount of dyspnea and less amount of cough. Okay, so just remember these things. And the complication in bronchitis is polycythemia, pulmonary hypertension, and cor pulmonale. Whereas in emphysema, you get more of bullae, that is air trap spaces, and you get pneumothorax due to rupture of the bullae, and weight loss because your muscles are overacting to push the air out, to increase your transthoracic pressure. So I'll stop here. Okay, thank you.
Thank you so much, sir, for such an elaborate and wonderful session. And today, almost 150 viewers have benefited from this live session. and it will increase post live also. So
Sure, sure.
thank you very much, sir, and hoping to see you in further upcoming sessions.
Sure,
Also.
sure. Thank you.
Thank you so much, sir.
Thank you.
We'll close the line.
Sure, sure. Thank you.
Thank you, sir.